Yes? Okay. So when we're going through, if you see a certain patient presenting and you're not quite sure if it's hypomanic or manic, try and make that distinction because that's going to tell you right away without knowing the full diagnosis of me saying this is bipolar 1, this is bipolar 2, that you guys should be able to take care of that and do that. The other thing is that even if a medical condition, say that the person has bipolar, we always want to make sure when we're making any DSM diagnosis that we're ruling out there's not an underlying issue anyways, right? But say you're coming up with a bipolar diagnosis. I've had students ask me, if you have, say, a person on a medication and it induces a mania, not a hypomania, but a mania, would you classify that person as a bipolar 1 patient? And the answer is typically yes. Because if they're not going to be, if they're going to present as a manic patient, okay, most patients, if they're going to do that, it's almost like a predisposition if you're using that drug and it drove them into it. Now, you know that picture sounds like it's a little cloudy, but you want to make sure that you're really looking at your diagnostic criteria being on the ball, because if you're kind of treating a little bit more for, say, a depressed patient as with, you would for a manic patient, the therapies, as you guys will kind of look at in the article, don't always match up perfectly, okay? So we have preferences of one versus another, and you want to make sure you're keeping those in mind. So does everybody feel comfortable so far with the medical conditions that can trigger in mania, a basic understanding of the pathophysiology of the disease, and why these that you see listed here, if you think about why bipolar presents itself with the chemical imbalances anyways, do they all kind of make sense when we went through them? Do you want me to cover any of them again? Are we okay? Excellent question. You're always going to focus on the underlying condition that would have exacerbated an acute manic episode. Always. So, rule of thumb, you're always going to treat the underlying issue first. Okay? But most of the time, again, if we're going into a full-blown manic phase, that's why we look at it as a manic episode, and that might not be classifying them as a bipolar patient first, right? Remember, typically patients are going to present with depression first, and then they'll have hypomanic or manic episode later. If there's something that's actually triggered, you have, like, say I put a patient on steroids and they develop mania. You're typically going to expect that person to end up with a bipolar 1 diagnosis, but you can't do it at that point. So when you're looking at therapy overall, you're going to probably be looking at more of that line of therapy. But that initial diagnosis, you're going to hold off on making until you see that that presentation is following that pattern. Does that make sense? Okay. Anybody else have questions on that? We good? Okay. So specifically too, when I went through the medications, try and make sure you guys are familiar with these overall, because in terms of when I'm giving you, say, a case or an exam question, any of the drugs that you see listed, you really have to have familiarity with these. You have to know what to trigger that patient potentially and know how to counsel them. So especially more of your common medications that you're going to see, for example, like your steroids, your Isodex, the isoniazid, you're going to see particularly in your TB patients, so maybe not as commonly, but especially your benzodiazepines and your alcohol, which we know a lot of our patients have used anyways. Please make sure you're familiar with these. And of course your antidepressants, which ones are going to have a greater chance of inducing a mania. We talked last time, your major classes, your SSRIs, your SNRIs. SNRIs, because of the norepinephrine effects, they haven't shown significantly that much of a difference versus SSRIs for maybe inducing somebody, inducing a mania in patients. But because of the norepinephrine and the serotonergic effects, you would expect that would, almost have more of a predisposition to throwing somebody into that than, say, an SSRI. Remember your dopamine agonists, like your Wellbutrin, remember that's the lowest switch rate of all the antidepressants, so that's usually if we can use it when we look at its first line. And if you're looking at other therapies, we didn't go into it too much last time, but if you think about how your other antidepressants work, even your tricyclic antidepressants, which are a little older, but we will sometimes still see commonly used in a good number of our patients. and your MAOBs. You're still going to have to watch out across the board because if you think of those mechanisms of action, they're all working on serotonin and norepinephrine still, right? So you would expect that they would still have a good chance of having somebody switch to them as well. Okay? All right. So moving on. Oh, and the other thing to keep in mind is even with your herbal medications, try to use your herbal medications. Those are really stimulating. Anything that can potentially, like Huang, that's not really available anymore, you don't know that broke down into ephedra. But, anything that's got the stimulating properties to that as well as an herbal that in the back of your mind as well. Okay? So we already went through the other possible inducers. Any questions on these? Other possible inducers, we okay? All right. So, again, remember, when you guys are seeing the approvals here, for example, when we're looking at, say, the depression, lithium and methyl are generally we're looking at when we're treating our depressed patients as something that we use as a maintenance therapy in those patients as well. So kind of when you're looking at this list here and you're seeing maintenance in between, it would be for either class of bipolar 1 or bipolar 2. Potentially, you could look at those as being an option. Specifically, when we're looking at depression, you can see that Seroquel, Abilify, and Symbyax, which is olanzapine and fluoxetine combination, are approved for depression. But it's not to say that looking at our gold standards of mood stabilizers, specifically in our depressed patients, again, lithium and lamictal tend to be one of our mood stabilizers that we'll use very, very commonly in those patients. They've got the data supporting that they're probably efficacious and can be a treatment of choice. Okay? So, again, adjunctive therapy, remember your benzodiazepines. Okay? These are always going to be used, especially in our manic patients coming in for short-term adjunctive therapy in addition to what we're going to hopefully stabilize them on a little bit longer term. Again, we're going to make sure that you're going to taper these off over time, and you want to do that, over the course of a couple weeks, so you're not going to have almost a rebound anxiety if the drug withdrawal, is part of the issue. Okay? Anybody got questions on the benzodiazepines? One of the things I wanted to mention when I was going over benzodiazepines with you as well is that similarly in our schizophrenic patients who say we may need to give an as-needed medication. Remember I mentioned the Haldol, Ativan, Benadryl, the B52. When I mentioned B52, I don't know if you did any of you guys get the acronym, kind of if you look at it and figure out what the B52 stands for, Haldol, Ativan, and lorazepam. So B for Benadryl, 5 for Haldol, 2 for Ativan. We still will use similarly in our acutely agitated and hallucinating bipolar patients, similar combinations to that. We do have, as we went through in schizophrenia, you saw a lot of those are available as an injectable form for acute agitation. So when we went through them, and you'll see them again here, we still will say employ our IM Zyprexa, our IM Abilify, our IM Geodon, and some of our typicals, for example, like our Haldol, our B52 shot, that we will use in those patients as well. And again, hopefully once you get them out of that initial day or two, could even be up to a week when they're actively hallucinating, and kind of bring them back down to hypomanic and closer to what we would prefer, when out of a manic state, that you will see those be something that acutely that we'll use on a regular basis. So the benzodiazepines, in terms of your B52 shots, makes sense, but also if you're giving a short-acting an intramuscular agent like the Geodon, Abilify, Zyprexa as well, you often will give a benzodiazepine in addition to those as well. Okay, so kind of Ativan, 2 milligrams, up to 4 milligrams potentially that you would give in those agitated patients is something that we'll see employed a lot. Okay. Remember, in terms of concomitant antidepressant therapy, that you want to be very careful when you're treating your depressed patients, especially in your rapid cyclers, if they're mixed bipolar or remember what mixed bipolar is? Anybody want to tell me what mixed bipolar is? Remember? So, one day they might be manic, and then you start, seeing them all of a sudden dip down into a depression, which clinically is interesting because we know normally when we're looking at those episodes, it takes over a little bit more time, but specifically in those mixed bipolar patients, especially, the mixed patients, they'll cycle through much faster. You have to be especially careful in those patients with antidepressant therapy because we know that a lot of the time it's going to just flop them over to the other side. Okay? All right. So when you are looking at your patients that are presenting with hypomania, remember if they're bipolar 2 patients, it doesn't necessarily mean that they're going to require treatment. So again, bipolar 2 patients, this is going to apply more than your bipolar 1 because a lot of the times in your bipolar 1, when you see hypomanic, that's a trigger to make sure you're treating them so they don't get into the manic stack. But if they're bipolar 2 patients, you're just going to make sure you're observing them, make sure they're not switching over to a full-blown mania. It may not necessarily require pharmacotherapy in those patients. Not to say that we might not have them hopefully on something as a maintenance so they aren't fluctuating as much when they're coming down from that hypomanic episode and dropping into a major depressive side of things. But especially in those, you're just going to make sure you're doing much closer monitoring if you are deciding not to do therapy especially. Okay? Acute manic episodes should be treated with a mood stabilizer always. Okay? We generally are looking at the ones within the anti-epileptic drugs like carbamazepine, valproic acid, and lithium. Lithium, as I mentioned, of course, it's got lots of nasty side effects, but it still is looked at as a gold standard of therapy for treating bipolar disorder. And you're usually, again, going to look at your adjunctive benzo, and that's going to hopefully deal with some of the sleep issues that will present and the anxiety issues that will present as well. If you're having psychosis, you're always going to look at your antipsychotics in addition to that, okay? So this is general rule of thumb. It's not to say that in every patient that I might not just look at, say, Seroquel versus lithium, carbamazepine, or valproic acid if we're thinking that's appropriate. But generally, when we're looking at acute manic episodes, one of those three are going to be used because they tend to be, in terms of efficacy, they have the backup, the studies behind it showing that they are the most efficacious. Okay. When you're looking at responsiveness, so if you have no response within 2 to 4 weeks, you're going to look at your second mood stabilizer in addition to what you started out with. Okay? And if the patient's still not responsive, the mood stabilizer should be switched to another agent, or ECT can be used at that point. All right? So you know that it can take a little bit of time to see the full benefit. Usually within 2 weeks, if we're not seeing any improvement, we're going to be switching. If you're maybe seeing partial improvement, you're going to be adding something on for sure at that point, okay? After a person's in remission, adjunctive agents are tapered, again, slow taper, over 2 to 6 months. So not something that, you're going to look at like a lot of your other drugs, like the overall half-life of the drug, 3 to 5 half-lives, do a slow taper. No. We want to make sure we're doing this extremely slowly so we're not going to induce another episode. So over 2 to 6 months, please remember that, okay? After the patient's responding, if they again have had only 1 manic episode, they're going to continue on the mood stabilizer for 12 months. So 1 manic episode, 12 months, then you can consider coming off. Again, if they have more than 1 episode, as I kind of wrapped up with a little bit of this last time, that we're going to make sure that we're almost looking at it as a lifelong therapy that they should be on something. Okay? Any questions on that? Everybody clear? Yes. The first episode, and you only have 1 episode, yes. Generally, that's not something you're always, if they've had their depression and then they've had their manic episode after that, and it's a one-time thing, that's the only time you're going to assess it. If they've had more than 1 manic, even hypomanic episode, you're usually going to consider it as lifelong therapy. All right? Okay. So yes?
When you use electroconvulsive therapy as kind of like last resort, is like even like, even like third line therapy or something like that?
Absolutely. One of the things is kind of like, when you're looking at, say, just a depressed patient, and you're using ETZ, even in that case, most of the time it's going to be pushed off till, last resort of therapy because of the fact of the potential for short-term memory loss. So So we want to make sure, similarly in bipolar patients, it's kind of when nothing else is kind of working that we're going to end up with that. So I've got it listed there, so I want you guys to be aware that it is still implemented. But remember, specifically ECT has been known to induce a higher chance of mania potentially. So it's really for those patients, especially in those bipolar 2 patients more so is when I'm going to see that implemented. Not to say in our manic patients that if we can't get them under control and we've tried everything else, we will still sometimes try that. Okay? But yes, you're correct. It's more or less fine. All right? Any other questions, guys? Okay. So looking at our overall drugs now, fun stuff. Right? All medications that we use can take days to weeks to work. Okay? Kind of similarly, when we're looking at any psychotic patient, it's usually going to take some period of time to get them out of that and then have a response to therapy. Similarly, in your schizophrenic patients. Within your bipolar population, if it's a patient presenting with psychosis, they'll usually respond a lot quicker. Again, I know I mentioned this last time. They'll respond a lot quicker than our schizophrenic patients in terms of their psychosis and hallucinations most of the time. Okay? Again, lithium, kind of our gold standard drug has been used over many, many years. Anybody know the soda that used to have lithium in it? 7-Up, right? So back when that first came out, they actually had lithium in there until they ended up having some reports of renotoxicity for apparently those heavy 7-Up drinkers. So, it definitely gave you an up, maybe not want to have the side effects after the fact. But the anticonvulsants, the 3 that we're typically going to look at again, depakine, valproic acid. Remember, valproic acid and divalproic sodium are the same thing. Basically, what divalproic sodium is 2 molecules of valproic acid, and then when it gets in the gut, it breaks down to valproic acid. And we'll go into that a little bit more. But then our antipsychotics, which have been approved as mood stabilizers as well. Okay, so those are the ones up there: Zyprexa, risperidol, Geodon, Seroquel, Abilify, and Clozaril. Okay, so not to say that you wouldn't expect some of the others that may not be listed there to have efficacy, but those are the ones that have studies and have approval in bipolar. When you're kind of looking at the anticonvulsants in general, and I'm not going to spend too much time when we go over the drugs individually, but you can kind of think of the mechanisms of actions of anticonvulsants as a whole. It's thought that when you guys go back to maybe some of your pharmacology and med chem stuff, and you look at the mechanisms of action of some of your anti-epileptic drugs, the fact that they're going to work on sodium channel blockade, some of them working on the calcium channel blockade, overall in the brain, what you're wanting them to do is decrease the excitability of the brain, okay? And if you want, I have it broken down in that slide under the notes. I saved my notes for you guys on that if you want to read it about that a little bit more. But it's interesting that you would think of some of our anticonvulsants work very well as mood stabilizers, and some are completely ineffective, okay? So, some of them, even though we're not looking at them as overall mood stabilizers, still have some properties where they may help with bipolar, but we shouldn't be using them as a maintenance medication, and we'll go over that a little bit more. But for example, Topamax. Topamax is one of those drugs that has been used for lots of different things. It's used for headaches, migraine headaches. It's used for, it's been used for weight loss, okay? Obviously used for epilepsy, and it was commonly used without the studies to back it up for mood stabilizer as well. Overall, I don't want you guys to look at Topamax as being a therapy that we would ever recommend for bipolar patients. Look at the studies, and the efficacy is just not there. But there are some traits that make sense to you why it might help out with certain attributes of disease. So, overall, again, remember the 3 that I've got listed there. Kind of, if you're thinking about Tegretol, okay, carbamazepine, the prodrug from that, when you look at it breaking down, is similar to oxcarbazepine, okay, trileptal. You guys ever seen or heard that drug before? Great. So when you're thinking overall of the side effects of carbamazepine, trileptal, because of the reformulation of the drug into oxcarbazepine, that drug has, though it has similar side effects, they're much less than carbamazepine. You don't have to worry about the enzyme-inducing interactions that are going to happen like you do with Tegretol. So even though that one's not FDA approved, a lot of doctors will use that as a mood stabilizer because it doesn't require as much monitoring. You don't have to do blood level monitoring. The hepatotoxicity is not as bad. So when we're going through again, and I'm talking about carbamazepine, kind of keep trileptal in the back of your mind as something that at least makes a little bit more sense, though it doesn't have the approval for it. Okay? Any questions on that? We okay?
What about the bioavailability of the oxytocin?
Overall, as long as you're looking at, the patient's still taking it a couple times a day, it's not too much of an issue in terms of the food and all that. It's not too much of a concern.
More or less viral?
If anything, you don't have to worry about the auto-induction and all the other nonsense of the PK you do with carbamazepine. So in terms of being more available, I would probably say you've got less of an issue to worry about with the trileptal. Again, it doesn't have the studies behind it saying we should be using it as a first-line agent, but it makes sense if you guys are seeing it clinically that I wouldn't be calling the doctor up right away to change therapy versus if I saw somebody say on like a gabapentin or Topamax or something like that, another anti-epileptic drug that was used off-label for bipolar and switch other factors. Okay? Any other questions guys? Okay. So lithium. Lithium is about 70% effective for acute manic episodes. So that's a pretty good result overall compared to most of our other therapies. About 20 to 40% either don't respond or can't tolerate it. So that's when you're starting to look at your other agents, for example, like your Lamictal, carbamazepine, Tegretol, or your atypical antipsychotics. Okay. When we're looking at those that are rapid cyclers and mixed bipolar disorders, this is definitely something we're going to be looking at as our first-line therapies because it does have higher efficacy in that population compared to the other therapies. 20 to 50% are going to have a relapse rate over 2 years, whether that's attributed so much to just the disorder, they need an adjustment of their medication, non-compliance, whatever it is, that's the average overall. Not taking into a lot of the other considerations that happen. So it's not just saying that that's those patients that are taking it and we know that they're taking it and looking at blood levels and all that. That's overall, okay? Half-lives are going to range from 18 to 36 hours. So one of the things in terms of pharmacokinetics, you can look at a patient and say, overall, you probably could give it once a day. But from what you guys have seen, do we do that? Is it okay to give lithium once a day? What do you think? No? Why?
We want to have lower peaks,
Mm-hmm.
and so frequent.
Exactly. The peak and the trough with this drug, especially because it's very neurotoxic, right? Or renotoxic, okay? So on the tubules of the kidney and the damage that can cause with that, we don't want to have to worry about having higher peaks. But more so than even that issue is the GI. GI issues with lithium are huge, okay? So when you see this half-life from 18 to 36 hours, you may see some patients that get it, say, once a day at bedtime, because it's a little more sedating if you're going to give it once a day. But typically it's going to be dosed a couple times a day so we can avoid a lot of the side effect profile of it, okay? Caution in pregnancy and breastfeeding. Epstein's anomaly is a congenital malformation of the heart that occurs. So if you do have a patient that's bipolar and wants to get pregnant, we want to make sure, especially within the first trimester, if we can potentially avoid that, we will. It is a good percentage of patients that do end up having fetuses that end up being born with that cardiac malformation, okay? Now that's a difficult one because, remember, when we're talking about bipolar patients in general, if we're using this as a standard of care for being, very efficacious, we're hoping that it's targeting some of that, hypersexuality that kind of goes along with that side of things. But it is reality that in our pregnant patients that it's something we need to caution them on before they start the drug and make sure they know that they're kind of using a secondary contraceptive agent in that case, okay? Toxicity can be fatal, and we're going to go into that much more, but it's kind of interesting for you guys to know that this is the only psychotropic drug that you can dialyze that will help in terms of an overdose. And it's not to say that it's going to be perfect, because a lot of the times when you're having the acute toxicity, it's going to kill the kidneys pretty quickly, depending on the dosage that you're looking at. But the toxicity of this definitely can be fatal, where some of our other drugs, it's not as much of an issue. Okay? Looking at the formulations, there's immediate release and controlled release. Most of the time, we're always looking at controlled release because of the fact that you don't have to worry about as many of the GI side effects. Patient does, in terms of remembering to take their medications, in terms of compliance, we know it's a major issue with our psych patients, especially our bipolar patients, which don't want to think that there's an issue half the time, or like the fact that they're going into the manic side of the disorder. In terms of the overall, looking at Esclif and Lithobid, there's a lot of different formulations. The lithium carbonate is the generic. That, they basically, overall, in terms of their efficacy, are about the same. If you're using it for prophylactic therapy, 80 to 90% effective. So that tells you, again, it's pretty good. So when I'm telling you guys about 70% in a work for an acute manic episode, when you're looking at prophylactic for having a second episode, very efficacious, 80 to 90% there. Okay? Does have some calcium blocking activity, which again will help decrease the neuroexcitability in the brain. It's administered in a salt form, and it's interesting for you guys to know. And it's actually very important, especially depending on what season you're in or what area you're living in. But if you have a patient sweating a lot, that actually can spike their lithium levels. So I can tell you, when I was in Florida, one of the major counseling points I gave is do not ever let yourself get dehydrated, because you can actually, even on a normal therapeutic level, you get dehydrated, you get those lithium levels spike, that can be toxic. Okay? So kind of when you're sweating, because of the salt form and the lithium itself, basically what that does again, remember, that's going to spike the blood levels. All right? Looking at your overall dosage, you're usually going to start out around 300 milligrams twice a day, up to 900 milligrams TID. Blood levels with this are incredibly important, guys. If you're looking at an acute phase of mania, the blood levels are 0.8 to 1.2, potentially up to 1.4 in severe patients. Now, saying that, not even looking at the maintenance yet, but let's just look at the acute phase. You have somebody coming in and you're treating them. Above 1.0 of a blood level, you definitely can start to see signs of toxicity. Okay? So very narrow therapeutic window. Even our maintenance phase, 0.4 to 1.0. Okay? Higher levels in the maintenance phase, and sometimes you need to have patients closer to 1. You need to be very careful that you're looking out for the overall toxicity. We're going to go into what those are a little bit more in a second here. So one of the things, before we even get into all the side effects, any patient that you're going to start on our lithium, you have to know your baseline assessment and monitoring parameters, because this drug can affect everything you see listed there. Okay? Serum creatinine, as we know, it's rhinotoxic. You're going to pay very close attention to that. Urinalysis, osmolality, and specific gravity, again, kind of looking at the renal function, making sure all that is where it needs to be, and that we're not damaging the kidneys. CBC with differential. Interestingly, lithium can increase white blood cell counts. So if you have a patient taking lithium and they come back with a white blood cell count of, say, not too high, maybe 17, you want to make sure you're not mistaking that for, say, an infection, that it's actually because of the drug itself. And in some cases, when you're trying to boost patients' white blood cell levels, they'll sometimes even use lithium to do that, off-label, if they're having an issue with that. But we know that that drug does that, so you should know that it increases white blood cells, and that's actually just an ADR of the drug. It's not anything that's too clinically significant. Okay? Serum electrolytes and glucose. So we want to make sure, especially that we're, again, making sure the patient's not dehydrated. Okay? Making sure that we're, again, looking at the creatinine, making sure, so you definitely want to be looking at your Chem 7, or complete metabolic profile, your CMP, okay? From 14, whatever you want to call it. Serum electrolytes need to be part of what you're monitoring, okay? The weight, lithium can cause weight gain, okay? So you're going to want to monitor that from the beginning. It can be cardiotoxic. It can cause arrhythmias in some patients and other cardiac abnormalities. So you're always going to look at the EKG for a baseline. Make sure you're looking at the pulse and blood pressure, that cardiovascularly the patient is in a good state before you start this drug. Okay? CFTs, thyroid function tests. So we know that, especially the longer patients on lithium, that this can actually damage the thyroid and cause hypothyroidism. Okay? And it's 10 times more likely in women. So we need to make sure, especially in our patients that are on lithium long term, we're always monitoring thyroid function tests, at least every year. Okay, at least. Sometimes more than that, right? And then a full history and physical to find out if the patient would be appropriate for therapy or not. If they're not taking, very good care of themselves, they're not, eating on a regular basis, and you're worried about maybe, periods of dehydration, and then they're, kind of taking fluids, and you're going to have levels fluctuating back and forth, take some of that into consideration. Do they have a good social support where you know that someone's going to be kind of monitoring them to find out, if they're, what are the signs and symptoms of toxicity? Are they abusing alcohol and other illicit drugs where that might be, part of the problem? So history with, as I know Dr. Teeter mentioned, I'm going to make sure you guys know, always taking a thorough history and physical exam with these patients before you would consider therapy, especially in lithium patients. Okay? Looking at the PK of the drug, it's readily absorbed from the GI tract, so we don't really have to worry about administering it and too many issues with the uptake of the drug in the GI tract. Peak serum levels occur within 2 to 4 hours, so if you're going to see side effects a lot of the time, that's when you're going to start seeing them present. And it's usually complete absorption within 8 hours. So depending on the formulation, if you have a slower release, if you have a CR formulation, that's extended. But if you're giving immediate release, we know within 8 hours it's usually complete absorption of the drug. Okay? Again, because of the absorption and uptake in the body, total body water is very well distributed. No protein binding issues with this drug. Okay? The cerebrospinal fluid concentration is about 40 to 50% of that on the plasma, so that's how much it's really getting into the brain, right? So, crossing the blood-brain barrier, BBB, that basically you don't have too much of an issue of getting it into the brain compared to, say, a lot of other drugs that have more of an issue with that. So the brain concentration is always, we think of about half that of the plasma, all right? So that also means in terms of, your toxicity, when your plasma levels are elevated, you can account for the same amount that's getting into the brain. And conversely, concentrations that are low, if you're having too low of your blood levels come back, obviously, same thing. You're not getting enough drug into the brain where we need it to be for efficacy. All right? Again, highly renally eliminated, so over 95%. About 80% of that's reabsorbed in the proximal tubule. If you just look at the overall elimination of the drug, makes sense why it's very renotoxic. And 20% is excreted in the urine. Because it's reabsorbed, you basically have this reabsorption and excretion, reabsorption and excretion. So that 20% you see is kind of like you'll get the 80% reabsorbed and then the 20% excreted, and it'll kind of keep going through that in terms of the metabolism of the drug. Okay? We mentioned the half-life. Depending on age, I want to make sure you guys are aware that the elderly, this is definitely going to decrease. When you guys get into your therapeutics too, and you learn a little bit more about your renal pathways, you'll know that the older you get, the less clearance you're going to have from the kidneys. So when we're starting in elderly patients, we're going to usually do is half of what we would in any other adult or adolescent patients. Okay. Especially if they're renally impaired, it's not typically going to be looked at as a new drug. But sometimes we will. I remember a case that we had a patient with, she was on lithium. She ended up having an acute renal toxicity, came in, got dialyzed, just couldn't quite get the kidneys where we needed them again. We tried her on Lamictal, we tried her on carbamazepine, we tried her on all kinds of combinations, nothing worked. And despite the fact that she was renally compromised, we knew lithium worked, and we just made sure we monitored her extra close when she was on a low dose. Sometimes you're going to have to do that. So just paying attention to renal function, and those times you do have to do that, you're going to make sure you're adjusting for it. Okay? And then concomitant drug use. So there's a lot of drugs that are going to alter lithium levels, and we're going to go through what those are. So what does this mean for dosing? Looking at how you're going to start the drug. Always going to initiate low and start slow and then slowly tighten it up, okay? Low and slow, all right? Again, starting at 300 milligrams twice a day is usually where we're going to start at. Some doctors will even split it up to say, you know, even lower than that, say 150 milligrams, and spread it out a little bit more. Depending on the patient's age especially. Elderly, again, you're going to usually start at 150 BID, okay? You want to make sure, obviously, when you're starting it out, you're going to look for clinical improvement, and, you know, you may not be getting up to the dose you normally think of. When the patient's demonstrating efficacy, you don't always have to kind of go up to the higher side of the levels. When you see efficacy is kind of when you're generally going to stop, as long as you're within the lower threshold of the levels. And what you guys remember, always treat the patient, not the level. So we're worried about toxicity, we're worried about efficacy, you're always going to look at those for a baseline. I do have some patients that, you know, their lithium level would be, say, you know, 0.4, and, you know, doctor would come in and say, oh, that level is low, maybe we should bump it up a little bit. No, if they're responding well to therapy, that's fine. You know, even if it's a little bit below that, you know, say they're, you know, 0.35 or 0.3, probably as long as they're responding, not going to touch it, okay? Steady state serum level determination after 4 to 5 days of each dose team is when you're going to get them up to that new level. So clinically, if I'm starting somebody in the hospital on lithium and I want to get their drug levels, if I'm drawing it at day 3, which happens a lot clinically, it's not a true drug level. You really need to wait, we usually say rule of thumb 5 days, okay? You want to make sure you're drawing levels 12 hours post-dose, so you're getting a true peak of the drug to come up at that level. Okay, so we're not drawing it during the peak, we're drawing it during the trough of the drug. Okay, and once maintenance therapy is achieved, you're going to monitor every 2 to 3 months all those monitoring parameters we went through in the beginning to make sure that we're not having any toxicities, look at therapeutic efficacy, and the latter. Okay, when we're looking at side effects, okay. So lots of them, okay? Fine hand tremor, it's kind of very characteristic with kind of like a very fine hand tremor. When it starts getting coarser, you know you're at a toxicity level. This is actually before we had blood levels with lithium, how doctors used to dose lithium, okay? So fine hand tremor, they consider therapeutic. It got too coarse, they knew they had gone too far, okay? So back in the day, that's what they did. You can help out if the patient is presenting with that fine hand tremor with beta blockers. They can decrease that, but usually what we'll try and do is, if possible, we'll decrease the dose a little bit so the fine hand tremor will go away, hopefully that they're still therapeutic. Okay? Polyuria and polydipsia. Again, think of what this is doing in terms of its elimination. It can cause, you know, an increase in thirst and an increase in urination. And that's seen in about 70% of patients. So you want to caution them that that's a side effect of the drug. If it's happening a lot more than normal, then we need to make sure we're taking a good look at levels and we're not causing toxicity and not shooting out the kidneys, okay? And then the opposite of that, what happens is when you actually do get into kidney failure, is it polyuria you see? What happens when your kidneys shut down? Anybody think of, say, a chronic renal patient? I know you guys haven't had that, but you know anybody that's got chronic renal failure? They don't pee. Okay, so that's how you know if all of a sudden that changes and they're not going, that maybe there's some toxicity going on there. You're usually going to see a lot of the other side effects as well when that happens, though. Okay? Again, weight gain, significant concern in a lot of our patients. About 20% of patients are going to experience weight gain, so not everybody, but it is something we want to caution them and make sure we're monitoring for. Again, the hypothyroidism and actually goiter, the little don't stir the goiter thing, that helps you guys remember. In terms of hypothyroidism, if it's not treated, it can actually cause a goiter like any other hypothyroidism that's not treated for a long period of time. This can develop after years. I've definitely seen lithium patients come in that have got a goiter going on, and it's something that, you know, cosmetically isn't that appealing. All right? We want to make sure, especially in our women, remember, 10 times more likely in women, it's generally irreversible. Once you're killing that thyroid, you're going to end up having to take supplementation therapy, and it's generally irreversible, okay? If you catch it early, there has been some instances instances of it kind of, improving, but that's again why you really need to make sure you're looking at those thyroid function tests, and if it is causing some damage, you're catching it early and potentially looking at another therapeutic option, okay? Also can cause some leukocytosis. Again, the EKG changes is why you're going to look at that in terms of your baseline. Neurologic issues, for example, like ataxia, gait disturbances. You can kind of think of, if a patient's presenting with lithium toxicity, they actually look like they're drunk. They're going to have trouble walking, they're going to be slurring their speech, slurring their words, kind of falling all over the place, okay? So even to a lesser extent, when the patient is not in a toxic level, you can expect that there would probably be some potential neurologic side effects that are associated with that, okay? Dermatologic issues, and it can have potentially some issues with rash and other skin issues where hair is actually falling out in some patients as well, okay? Can decrease libido, which, if you think about our manic patients, means that it's probably working, okay? Generally, that's not an issue in terms of sexuality, so they may not be liking that. You need to let them know that that's actually what you want to be seeing some of the time with those drugs. Now, that can be problematic, say, if you have somebody that's bipolar 2 and more on the depressive side of things, that you might want to improve that, but it's just something you have to make sure you're paying attention to, especially in your male patients. You just would basically be doing a regular erectile dysfunction screen in your men, okay? Metabolic or metallic taste, so this actually is seen in a good number of our patients where it's got like this metal taste, metallic taste in their mouth that occurs. And then, as you would expect with the polyuria, the urinary incontinence can sometimes be an issue. All right?
Shit ton of side effects.
Yes.
Is this polyuria maybe potential for lower blood pressures?
Yeah, anything that you're going to have polyuria can potentially decrease your blood pressure, yeah. So you can sometimes see the, hypertension would be an issue as well, and make sure we're monitoring it. That, again, baseline monitoring, soft blood pressure listed here, you're exactly right. Very good. Early side effects that you're usually going to see when the patient starts the medication are almost always going to be GI related, okay? That's again why we're going to split the dosage up, and we're almost always going to give it with food and give it as a controlled release, okay? So with food, controlled release, and split the dosage up. You also can see some muscle weakness and just overall lethargy that's going to occur with this. The patient's going to often complain of feeling a little tired, somnolent. Some of the other neurologic, communicable neurologic, the common ones you're usually going to see early on would be a little bit of headache, confusion. You're going to have some decreases in memory and concentration. Once the patient gets stabilized on the drug and starts tolerating the medication a little bit more after a period of time, those will usually resolve and improve if they have occurred, okay? So again, this isn't going to happen in everybody, but typically if it's going to occur, it's going to happen earlier on. Tremor, you can see from the very beginning, sometimes that may improve as well the longer the patient's on it, sometimes not. Dry mouth is another one that you can kind of think of as much polyuria that's probably going on as a secondary to that. Okay, and then again, leukocytosis you'll see early on as well. Looking at late stage, so the nephrogenic diabetes insipidus, because of the potential damage to the kidney, and again, the hypothyroidism like we talked about. Toxicity, so again, what you need to know if a patient comes in and looks like they're drunk, and you're looking at their alcohol level, and there's nothing there, what's actually going on. Especially in psych, we're usually, doing a check for lithium in those patients, okay? This is clearly related to the plasma level. So again, when you're getting up to levels above 1.5, usually, especially above 2, that you're really going to be worried about toxicity and the patient will be presenting like that. Usually when you're getting up to levels around 2.5 to 3, usually above 3, I would say, it's kind of like the rule of thumb. You're definitely dealing with some kidney issues at that point. When you catch it early enough, we can hope that it's reversible, but sometimes it's not. So again, major counseling points for your patients, okay? Overall, you're going to have a patient, if they're presenting with the plasma levels being toxic, diarrhea, they're definitely going to have some GI issues going on, okay? So your NVD, okay, nausea, vomiting, diarrhea. We know all three is going to be an issue. Again, the hand tremor is not going to be fine. It's going to be very coarse. okay? The hyperreflexia, so you sit there and try and hit their knee, it's going to go flying in the air, okay? The drowsiness, lethargy is definitely going to be presenting in those patients. They're going to be very sedated. Again, people appear very confused. They're going to have major coordination issues. Again, the ataxia, the gait disturbances. They're not going to be able to see clearly. They're going to have blurred vision, okay, for sure. That's going to be obvious in most patients, depending on the blood levels, of course, but the higher the blood levels, the more vision impairment you will see. Again, the urine, as you can imagine, if it's damaging the kidneys, the urine, when it's coming out, is going to be very dilute in the earlier phases of kidney damage, okay? You end up killing the kidneys completely again, then you get the opposite side of it, but early on, especially acutely, you're going to see a large output of dilute urine. So when you're looking at, say, the specific gravity of the urine, it's going to be closer to 1. It's going to be very dilute, okay? Again, we talked about the confusion, CNS irritability, slurred speech, the arrhythmias and hypotension. So especially in toxicity, you can see the arrhythmias. I know we mentioned that you're going to monitor for it even at therapeutic blood levels, but especially in toxicity, you're usually going to put these patients specifically on a telemonitor to make sure that it doesn't throw them into arrhythmias. Okay? Hypotension will be an issue. Seizures, coma, and death. So kind of what you would think about the fact that it's acting on calcium channels similar to some of our anti-epileptics, though it's not used as an anti-epileptic, okay, is, you know, you would expect something that's going to have an alteration in that to potentially lead to seizures, coma, and death, okay? And then if blood levels are above 3.5 MEP per liter, or even lower than that, you know, if we're really looking at toxicity, I would say clinically, if they're around 3, then we're usually looking at dialyzing those patients, okay? So that's always something that you're going to consider in that population.
14 slides.
If you catch it early enough in extreme toxicity, for acute ingestion, you can lavage these patients, and that's been shown to, you know, help some of the GI absorption if you catch it quickly, hopefully to prevent it from getting into the system in the first place, in addition to probably still considering dialyzing them. You want to make sure, especially because of fluid shifts and abnormalities, that you're making sure you're adding fluids into your system. You want to make sure that you're not having any chance of them being dehydrated, and the more fluid you get into the system, hopefully the lower you're going to bring down the lithium levels as well, okay? Because of the cardiac issues, you're always going to monitor cardiac and respiratory functions. You're definitely going to be on seizure precautions in the hospital. If you guys have ever been in a hospital, you know, you'll see like little warnings on certain patients' doors for seizure precautions. That's going to be something you're going to definitely make sure is in place. And then because of the fluctuations and the damage to kidneys and the reabsorption issues that the drug has, every 3 to 4 hours you're going to be checking that concentration and potentially be looking at the dialysis and the other options that you've got for fluid resuscitation and all that. Okay? So again, lithium is the only psychotropic that's dialyzable. A little factoid you can remember from now on. Okay? All right, in terms of drug interactions, as you can imagine, because of the fact of the issues with the kidney, that anything that's going to potentially be renally eliminated in larger concentrations is going to be more of an issue. So for example, like your NSAIDs, they decrease the renal function. That's going to mean lithium levels are going to go up. Diuretics, same thing. They're going to be putting some stress on the kidney. Anything that's going to potentially lead to the fact of having the patient lose fluids and you know, getting dehydrated, anything along those lines is going to increase lithium. Antipsychotics and antidepressants can add to the central nervous system effects that it's going to have, so especially those that can be more sedating and kind of compound that, okay? Conversely to that, we have other drugs that are going to decrease concentration. So some of your more stimulating medications like xanthines, like caffeine, which is interesting because we typically think of that as having some diuretic properties to it. That can actually decrease lithium concentrations. And it's basically where it goes down to is some of its effects on the kidney without going into major detail with that, okay? Cardiovascularly, a lot of our medications we need to watch out for specifically are ACE inhibitors. Again, we're attacking the kidney and increase the levels of lithium. Kind of seeing a theme here, right? It's affecting in the kidney, it's going to potentially affect lithium levels. Sodium chloride is inversely related to lithium concentrations. So if someone has a high salt level, it's going to decrease sodium levels. So if you were to have somebody come into the hospital and they were to have lithium toxicity and you were going to put them on fluids, what do you think you'd be thinking of? D5W or sodium chloride? Typically the two we're looking at a lot of times. You guys don't need to know about fluid resuscitation, more the fact that we want sodium chloride, right? So you'd be looking at sodium chloride as your fluid replacement versus, say, D5W. Okay? Is there any questions on that right now? Are we okay? That basically, depending on the specific drug using, the central nervous system, side effects. So mostly it's increasing sedation and it can compound that. Is it making more relaxed? Make you more active? Antidepressants don't always have you be more relaxed. Remember, especially as you're starting out the drugs, you use them to treat anxiety, and they actually can induce more anxiety before you normalize and stabilize with them. And some of them, though they, may be treating anxiety after a period, some of them are more sedating, right? So, especially if they're sedating more of your more sedating antidepressants, they'll add to that central nervous system side effect. Okay, did everybody hear that? Are we okay? Do I need to repeat the question? Are we okay? Give me a thumbs up. You guys are so quiet. All right. In terms of our patient information, because of the GI side effects, you're always going to recommend the patients are taking food or milk. You're going to want to make sure that they're, again, aware of the fact of potentially causing the dehydration issues. You want to keep them maintaining their fluids and their salt. So you don't want them all of a sudden switching to like a super high salt diet and then dropping off. It's going to have direct correlation with metabolism levels. Okay? Discontinue the medication right away and notify a physician if you can't find toxicity. So you have to let the patients know, if they are experiencing any of the side effects, they should go seek medical attention right away and make sure they're following up. And you're obviously not going to continue the drug if you're concerned of toxicity in that case. Okay? So this isn't, a lot of the times when we talk about toxicity, not to say that our bipolar patients, don't have the issues of potentially overdosing, knowing that there's, the high chance of suicide rates in this population in general. But we're just talking about normal therapeutic management. You can end up in toxicity if you've got certain things going on in these patients, like they're not paying attention to their food, they're not paying attention to their salt intake. So you need to make sure you're counseling that's really well known. Also, because of the fact, especially with the potentially fluctuating levels, especially if you're having a patient start out on the medication or you're increasing the dosage, that drowsiness needs to be something that they're well aware of. Even if they're, say, well tolerated on the medication and haven't really noticed any drowsiness, whenever you have, especially an increase in dosage, that can occur whenever they're increasing it. Okay. Looking at lithium overall, again, it's equally effective in preventing both manic and depressive episodes. Remember that overall you are going to have 20 to 30% of patients that are not going to respond to therapy. If you do have a patient that is a rapid cycler of having more than 4 episodes per year, that the overall response is probably not going to be as good in those patients. Now it's interesting because I mentioned to you guys, if you do have rapid cyclers, like those that are kind of having the mood fluctuations within a very short period of time, lithium is beneficial for that. But if you're looking at like the overall episodes, so we're not talking about a mixed patient, we're talking about, say, a bipolar 1 disorder, bipolar 2 disorder of like overall episodes throughout the year. More than 4 is a poor prognosis for lithium response. Okay. Atypical features such as delusions and hallucinations, you would probably expect with those in the acute manic side is, say, some of our antipsychotics. So again, that's sometimes why if they're occurring and you're starting patient on lithium, you're also going to use adjunctive therapy with an antipsychotic. Okay. Again, one of the times that polypharmacy is a little more acceptable. Okay. And let's see, 5 more minutes.
In terms of
Or we got 15 more minutes.
counseling with lithium, how do you
Is it till 2? What? Isn't it till 15?
Yeah, she said 15.
Oh, 15.
Do like 20.
Yes, absolutely. So, especially if you have, your patients don't want to do healthy, you want to exercise and all that, because they're starting to get
So
full of
like
they need to be dousing themselves in water if they're going to exercise. If they're sweating, that means they're potentially increasing their lithium levels. So, as much as it's coming out, you need to do replace it. So it's not to say it's an exclusion for exercise. You definitely want to live a lot not there, especially times like the weight gain, right? Hopefully you can manage some of that. But just making sure they're well aware that they're not starting out dehydrated. We usually recommend if you're going to start exercising to make sure that you at least have a full glass of water before you start. And then after exercising, be well aware that, especially if you're starting to recognize side effects right away, have that fluid to increase the loss. Okay. All right, so moving on to valproic acid or divalproic sodium. So again, remember valproic acid and divalproic sodium, pretty much the same thing. Valproic acid is known as Depakein. Divalproic sodium is known as Depakote. Okay, valproic acid, if you're seeing, if you're thinking of a liquid formulation, you're always going to be dealing with valproic acid. In the Depakote form, most of those are going to be given enteric coated because of the fact that it helps prevent some of the GI upset that you'll see with this. That's basically the differences between the two of those. When I'm going to kind of using them synonymously because they're generally the same drug. Okay. About 65 to 70% are going to have response in the manic phase to valproic acid. This drug in particular with our very aggressive patients tends to be very effective. Okay? I can tell you, especially our aggressive male population, this is a favorite of ours for starting a patient out on Depakote. Not to say that we don't have to look at that in females potentially, but we're going to go into some major issues with using this drug in females. Okay? Less toxicity with this agent than lithium, but you do have to remember that where lithium works on the kidneys to have issues, valproic acid is hepatotoxic potentially. Okay? The liver, being a much hardier organ, can kind of take a punch and a punch and a punch and several punches, and has a lot more ability to kind of rebound to insult. So generally, if it's going to work on the liver, we know that it's probably going to be safer than something like lithium that's much harder on the kidneys. Okay? The therapeutic window is much larger. So when we're looking at our drug levels, normally you're looking, starting, say, if we're talking about seizures, we kind of have the same one mirrored for bipolar of the level of 50 to 100. You can go up, especially in acute mania, up to 125, and you'll have some cases that you'll go up to 150 as long as the patient's not having side effects. We'll go over that again. But, if you're looking, obviously, at the therapeutic window, that's much bigger than, say, lithium, where it's a much smaller window. Okay? It is very highly protein bound. So you do need to be concerned about other drugs that are highly protein bound because of competitive interaction. And other drugs, sometimes even those, for example, like Lamictal, we'll talk about this a little bit more, but Lamictal is one of those drugs that you'll commonly see, polypharmacy among some of the different agents used, and there's a major drug interaction there because of the protein binding issues. That it's going to spike lithium level, or Lamictal levels, I should say, sorry. It spikes Lamictal levels, and you need to be aware of that. We'll go over it more. The predictors of response for valproic acid, it tends to be a little bit better for treating our mixed or dysphoric bipolar patients. In cases of lithium treatment failures, this one a lot of times will be effective. Okay. In our rapid cyclers, again, this is another one that we'll look at as an agent that has good efficacy in that population. Because, if you think about how the drug's acting and the other approvals that it's got, for example, say migraine headaches and seizures, a lot of other neurologic issues that you'll sometimes see this used. This, in terms of when we talk about epilepsy, is known as the broad spectrum anti-epileptic. It treats almost all different types of epilepsy. So you would kind of expect that it's going to have a lot more of an effect in terms of, say, calming overall and settling things down compared to some of the other drugs we'll talk about if you think about that. Similarly, when we talk about carbamazepine, there's some similarities there, but this one specifically, if you look at the approvals, it makes some sense on why it's going to have some positive effects. Okay. In terms of the lithium treatment failures, if you do have somebody on lithium, this is almost looked at as like the second line treatment option if you didn't go to this first. It's kind of like our two our bigger therapies that we're gonna look at. If you have a patient that has substance abuse as well, this is a drug that has got a little more efficacy showing in that patient population. That it's got some good studies showing that can be beneficial. Okay. Whereas, for example, say you think of somebody that's abusing things, you don't typically want to have somebody that say it's a heavy alcoholic on something like lithium. Valproic acid goes harder on the liver in conjunction to the alcohol. You're going to monitor that obviously closely, but it's still going to be safer than someone that's not paying attention to that. Okay. Comorbid psychiatric illnesses, we do see this be beneficial and obviously not first line therapy in some of those, but for example, like anxiety and panic disorder, that can be some benefit. As I kind of mentioned to you guys, in terms of hostile behavior, this one has been shown to be more effective, so you kind of expect conversely to help out some of those areas, right? And in terms of irritability and aggression, as I mentioned, impulsive behavior, so especially, if you have someone that, again, even if you started out as like an ADHD patient and switched over to bipolar, some of those traits, that might actually have a better prediction of response in those patients. Okay? Looking at our dosages, we're usually going to be looking at an average dose of 500 to 300 milligrams per day, starting at about 250 to 500 BID to TID. And you can look at the maximum being on average about 60 milligrams per kilogram per day. There's a real easy way to remember how to start dosing in this drug. Okay, real easy. You take the person's weight in pounds and add a 0 to it, to the closest dosage, usually a little bit above that. So if I'm, looking at a patient that's 150 pounds, you're going to give how many milligrams per day? 1,500, right? And you'd split that out over a couple times a day. So you could potentially give it there's an ER dosage form of Depakote, so you could give 1,500 once a day, say at bedtime, or you could break it out in the other Depakote formulation of, say 500 TID, 500 in the morning, 1,000 at night, however you want to give it. So you guys should have an idea of how to treat a patient in terms of fast crisis stabilization. It's pretty easy. Their weight out of your, you're going to be around, hopefully the targeted dose to come up with a plasma level where you're going to see some efficacy. Okay? So as I mentioned, in acute bipolar treatment, 50 to 125 micrograms is going to treat for acute bipolar. Up to 150 has been used if necessary, but again, we're not typically going to go that high. All right. When we're looking at baseline monitoring, so because this drug has been known to cause thrombocytopenia and a little bit rare, but hyponatremia, you're going to make sure that you're looking at your CBC and your Chem7. You're still going to be looking overall at the patient's overall, elimination pathways. So though it's not going to affect the kidney as much, you're going to still look at things like serum creatinine, UNE in your analysis. Again, you want to look at thyroid function tests, not so much because this one is got as much of an issue, say, as lithium does with causing hypothyroidism, but specifically if you're looking at treating a bipolar patient, you want to do a baseline thyroid panel anyways to make sure you're not hypo or hyperthyroid to see some of the symptoms you're seeing. Okay? The liver function test in this one is probably one of the more important ones, as I mentioned. So we know that you can't actually see transient increases in your liver function test when you start out with this drug. That'll usually normalize. But anytime you see that, you know that the drug could potentially be hepatotoxic. Okay? And then neurological assessment, of course, and basic cardiac profile as well. Okay? So most common common neurologic symptoms, you're going to see the ataxia, dizziness, drowsiness, tremor. Kind of some of what you see up there is for the ataxia, dizziness, and drowsiness, you'll see, especially when we learn about epileptic drugs next year, they all do that. Okay, that's a side effect of almost any anti-epileptic drug. And then tremor potentially. This one's not typically like you would see for your lithium tremor, that fine motor tremor. This one's a little bit more subtle, and it's not as nearly as common as you would see in lithium. GI, again, is another issue. Again, it's why we look at the formulations of being enteric-coated. Giving it with food is a big one with this. You always want to counsel to give it with food to minimize the GI effects. Hematologically, it can cause increased bleeding times. So you want to especially make sure if you have a patient that's on anticoagulant therapy, that's a counseling point, very important. We don't want to have to worry about having somebody bleed out because we're not paying attention to that type of drug interaction. Okay? And then, as I mentioned, thrombocytopenia can also happen as well. Looking at the dermatologic, we already kind of mentioned the hepatologic, but the dermatologic, you can see some hair changes in alopecia in this as well, probably more so than lithium. Okay? The rash that sometimes occurs in this is usually a transient rash, and that usually kind of resolves like maculopapular rash. And a lot of times, again, it's just a basic side effect of the drug. It's not something that is going to persist. It sometimes resolves. Obviously, if it's getting worse, you're going to take that into consideration and continue the drug. But it is a more common one when you're starting the therapy out to just kind of let them know that that's sometimes unresolved. Okay. Weight gain. Yes. It's patient-specific. We usually within a week to 2 weeks, I would say at most. You would say basically if the rash occurs and it's getting to the point where it's becoming troublesome, then that's when we consider stopping it. But again, usually it's just a light maculopapular rash that goes down after about a week. The weight gain is much more significant in this one than it even is in lithium. Okay? Weight gain is huge with this one. I can tell you, especially in, say, our adolescent populations that will use this, that you've seen, like, even our teenagers pack on the pounds with this, so it's something you really need to pay attention to. And the big thing that you guys will remember anytime you're seeing valproic acid is it is definitely teratogenic, okay? All trimesters, category D. So even though the worst exposure is in the first trimester, what it causes is neuronal tube defects, which means it's going to end up dealing with the formations of the body. And you can see, especially in the first trimester, it's associated with spina bifida. And it causes congenital malformations of the heart as well that has been demonstrated. So very, very big to worry about in our female patients, making sure they're not getting pregnant on this medication. The other thing that you need to know about, which I don't have, I need you guys to add this in, is that it causes polycystic ovarian syndrome. Studies have shown in up to 42% of women. That's a large percentage, okay? 42% of women will end up with polycystic ovarian syndrome. Anybody know what that is? Anybody know what that is? How do you spell PCOS is the acronym you can kind of remember by the polycystic, Polycystic ovarian syndrome. Okay. Anybody know what that is? Anybody ever heard of it? And you get cysts on your ovaries, and does that sound like a good thing for females? No. It causes amenorrhea. They're not going to have irregular periods if they get them at all. Makes it very difficult if they want to conceive. So even if you were to stop this drug, they've got polycystic ovarian syndrome, it's not always going to go away. Okay? Again, it's very difficult to conceive, makes the menstrual periods irregular, can lead to potentially hirsutism, so increases in hair growth. Okay? Question back there? Question? No? Stretching? Okay, sorry. Okay, so definitely something we're going to want to avoid in our female patients as much as possible. Not to say that occasionally we won't have a patient that everything else has failed and this works great in, but overall, we really don't like to use this in our female population if we can avoid it, okay? It is a major enzyme inhibitor of metabolism, major interaction with lamictal, as I mentioned. So this actually doubles the lamictal concentration, so that's very problematic when we're looking at therapy of combining the two, and it actually has a specific dosage cap. Where if you're taking Lamictal and you're on valproic acid, it actually halves the dose for you in terms of that starter titrating cap. Okay? Lithium may increase epicote concentration, so that's another one if you're looking at that combination therapy you should have an idea of. Oral anticoagulants like aspirin or warfarin or any of the others, 5X, they can increase bleeding times. Again, you need to be aware of that interaction because you don't want to have to worry about that obviously kind of going to the opposite side of the spectrum in terms of our therapy for keeping patients anticoagulated. And in highly protein-bound drugs, as I mentioned, if you're looking at a protein binding, 97% or above especially, those drugs are going to see major interactions with. Okay? So for example, when we're looking at drugs like phenytoin, when you're looking at drugs like, say, our antipsychotics like Geodon, you need to be aware that there's going to be interaction there. Okay? And CNS depressants like, most of the drugs we're going to look at for treating, especially our manic side, it's going to have additive drowsiness. Sometimes it can even be synergistic, so it won't just be like, double the drowsiness. It can be like much worse than that, depending on the CNS depressant you're looking at. All right? So again, remember with Lamictal, they have a specific starter kit just for that.